All right, guys, so I'm going to go ahead and close out this poll and share the results. All right, thank you guys for doing that poll. We're going to go ahead and move on to the next slide.
Well, welcome everyone to today's webinar. Again, my name is Bridget Walsh. I'm a Senior Policy Analyst at the Schuyler Center. We are excited to offer this presentation in the Moving on Maternal Depression webinar series in collaboration with the Postpartum Resource Center of New York. The Schuyler Center is a statewide nonpartisan advocacy organization primarily focused on improving policies for those living in poverty, particularly children and families. The MOMD project, or Moving on Maternal Depression work, is part of our continuing efforts to connect and improve care and resources for pregnant and parenting women and their children. Moving on Maternal Depression was part of a national learning collaborative to advance policies that improve prevention, screening, and treatment with an emphasis on racial equity and culturally relevant practices in policy and systems management. Here in New York, we expanded the focus to include maternal mental health more broadly. While the national project has wrapped up, we hope to develop a state-level learning collaborative that can share best practices and information on maternal mental health issues here in New York. One of the projects for the MOMD initiative is this webinar series. I'm also going to take a moment to introduce our intern, Brittany Eskew. She will be available in the chat for any technical questions you may have. And now I'm going to turn it over to Sonia Murdoch, who will introduce the Postpartum Resource Center of New York and our speaker for today. Sonia?
Thank you, Bridget, and the Schuyler Center. Thanks for everybody for being with us here today. I'm Sonia Murdoch, the Executive Director and co-founder of the Postpartum Resource Center of New York. We're a statewide nonprofit organization, and we have been helping New York State parents-to-be, moms, dads, and families since 1998 get to the help they need for perinatal mood and anxiety disorders. Our statewide toll-free helpline is available 7 days a week with additional support from Moms on Call and family telephone support. We also provide online free access to a statewide perinatal mood and anxiety disorders resource directory. We offer education on perinatal mood and anxiety disorders through our training institute, including our Circle of Caring Support Group program, various initiatives such as Project 62, Lisa Merritt Briley Visioning Educational Series, and Take Care of You. If anyone has any questions regarding more specific services that we offer, please feel free to let me know at the end of the presentation today. I also would like to mention that this webinar is approved for one continuing education unit for New York State licensed social workers and New York State licensed mental health counselors at the cost of $15. Helping Hand Psychotherapy is recognized by the New York State Education Department State Board for Social Work as an approved provider of continuing education for licensed social workers and by the State Board for Mental Health practitioners as an approved provider of continuing education for licensed mental health counselors. So we will post the link in the chat for those who would like to take part in the CE unit, and Brittany will post that link. So before we introduce our speaker, I'd like to ask two more poll questions. Remember that these are optional and anonymous questions. The answers to these questions will be displayed for the audience to see. So thank you for answering them if you choose to. Give everybody a minute here.
Great, thank you. I'm going to hold the poll up for about 10 more seconds and then I'll share the results.
Okay, thank you very much. Moving on to, that's our contact information. So feel free to reach out to us further at Schuyler Center, Postpartum Resource Center of New York. So moving on, it's my great honor to present to you our guest speaker today, Dr. Martine Hackett. Dr. Hackett is an associate professor in the Department of Health Professions at Hofstra University and the director of Master of Public Health program. Her research and community-based work is focused on maternal child health, suburban health equity, and the intersection of health and housing. She is also the co-founder of the Birth Justice Warriors, an organization committed to eliminating Black maternal and infant mortality in Nassau County, New York. Dr. Hackett previously served as a deputy director at the New York City Department of Health and Mental Hygiene's Bureau of Maternal, Infant, and Reproductive Health, and also had a decade of experience as a television producer. She has a Bachelor in Fine Arts in Film and Television from New York University, a Master's in Public Health from Hunter College, and a Doctorate of Sociology from the CUNY Graduate Center. A warm welcome to you, Dr. Hackett, for being with us today, and much appreciation. So Dr. Hackett, at this time, please feel free to share your screen.
Okay. Great. Thanks so much, Sonia. I really appreciate it, and always a pleasure to work with you. And I also extend my appreciation for this invitation from the Schuyler Center and to be able to talk to you all today about this important topic. So let's see, I'm going to do a little maneuver here, or I'm going to share my screen. And so allow me a moment for a transition here, and we can get started. I'm also happy to be a part of this larger project of the Moving on Maternal Depression. And my presentation today is really going to try to help connect some dots from between current events with the coronavirus pandemic, with pre-existing issues around racial justice, and with maternal depression. So it's my goal by the end of this presentation for you all to have hopefully a better understanding of how these issues connect, what are some of the underlying causes that are at the root of these issues, and what are some of the ways that we can look to be able to address them. So let me start by, again, sort of pointing out things that we are already aware of. That during this pandemic, which is the worst pandemic in a century, really has highlighted many significant issues, many of which were already present. We know that one of the things that was quickly evident after the coronavirus started to appear in the United States is that it disproportionately affected people by race, ethnicity, and socioeconomic status. And so one of the things that we can say now, 8 months later, is that the coronavirus certainly has revealed the inequities and inequality that already has existed in the United States. And even more specifically, when we think about what that is, we know that that has manifested in the mortality rates. The mortality rates we know have been disproportionate in that they have affected Black and Latinx people much more at a much higher rate. And again, when we think about the reasons for this, we can certainly understand that there are reasons that are connected to pre-existing conditions and access to healthcare. But I want to suggest that when we are thinking about the reasons for what we have all observed, one thing that has also kind of been very evident is that what we're talking about, again, are sort of root causes that have always existed in the United States. So this headline from Scientific American, which many of you might be familiar with as a really well-known publication that really sort of sticks to the science, had this headline, "Racism, Not Race, as a Risk Factor for Dying of COVID-19." And I think that that's an important concept, this idea of racism, not race. So again, not just looking at the statistics and sort of saying like, well, it seems that, as I just mentioned, that Black and Latinx people might be having higher rates and mortality rates of COVID-19. But to really ask ourselves why. And this concept of really looking at that root cause, specifically the root cause as informed by racism, turns out to be an interesting thread that not only exists to help explain the reasons behind the disparities in COVID-19, but in other conditions as well. And of course, we can't forget that during the height of the pandemic, we also knew over the spring and summer, we also dealt with a lot of racial unrest in the United States as a result of the killing of George Floyd and Breonna Taylor and others. And so this was all happening at the same time to make us realize that perhaps we're talking about similar root causes. And one of the things that I think is an acknowledgement of that is that in many cities across the United States, including Milwaukee, Boston, they have declared racism as a public health emergency. And in fact, just 2 weeks ago, Northwell Health, which is the largest healthcare provider in New York State, has also laid this claim of identifying racism as a public health emergency. So I want to suggest when we're talking about the idea of the impact that racism has on the health of people, that we have to be able to recognize that this is not just something that's sort of on the fringes, but something that is quite quickly moving to the center of a way of understanding why things are the way that they are. In addition to this sort of framing of the reasons for the disparities or differences in coronavirus deaths, we also know that the subsequent shutdown of businesses across the country has also led to economic despair and an economic crisis. And so one of the things that we know is that this can disproportionately affect families. So we know that families across the United States, and I'm sure many of you experience this with your clients, that there's a struggle for families to afford diapers, wipes, formula, and the local fundraising efforts or groups that have sort of cropped up to be able to address this has been admirable. But again, it quickly shows how fragile the support system was before coronavirus. In addition, of course, to that need, we also recognize that the lockdown that happened in New York State though beneficial for reducing our rates and flattening the curve of the coronavirus pandemic, also created unintended consequences. And so the restrictions of keeping people in place also led to an increase in domestic abuse. And this is not just something that happened in the United States, but it turns out worldwide, this lockdown procedure did sort of, and as one can imagine, right, to be able to have a stressful situation of an unknown deadly virus and people in losing jobs, not being able to go out, certainly can impact the sort of already, tensions that might have already been there. In addition, we know that food insecurity has risen as well as a result of this pandemic. I'm sure many of you have seen images of cars lined up for food distribution, and in many of those news stories that are done, there's always the person that they interview who says, I never had to seek help before. I never needed help with putting food on the table. Yet we know that this is the reality of what this pandemic has done, the loss of jobs, and also just the overall insecurity that people have that might have been there before the pandemic, certainly makes it much more of a serious concern. And in terms of what that means in terms of the mental health status of people across the United States, this is a report, a very recent report from the Center for Disease Control and Prevention that assessed what, during this pandemic, what are people's mental health statuses and substance use conditions. And what you can see here is that 40% of US adults reported struggling with mental health or substance abuse, including a pretty dramatic percentage of those who seriously considered suicide. And those who are recognizing that this pandemic is triggering underlying trauma or stressors that, again, preceded the pandemic. So I want to suggest that when we are looking at mental health as an issue, especially now, we obviously need to be able, for families, we need to be able to put this into a context. And specifically talking about maternal mental health, we are recognizing that we are in unique times. Because when it comes to even the other consequences that we recognize happened as a result of the pandemic, is that hospitals were overwhelmed. And with hospitals being overwhelmed, the sort of normal use of hospitals, including for childbirth, was limited and restricted, especially as it related to the spread of infection. And we know that in the early days in New York State, that the number of visitors were limited for people who were giving birth. And this caused much stress and anxiety for the people who were giving birth during this time period. We, of course, also know that within a few months, the governor sort of had a little bit of a loosening of that visitor restriction, but it still didn't impact the overall stress that people who are pregnant were under. And certainly the idea of the pandemic affecting people's plans, upending what they sort of imagined for birth, is one effect, but I would also suggest that those underlying stressors that were there again before the pandemic were also made worse due to the restrictions for COVID-19 when it came not only for support that was available at the in the hospital, but upon release, because as we know, people were also released early from the hospital. And we recognize that support and family support was limited as well upon discharge. The idea that older adults were at more risk for, and still are at more risk for COVID-19, also made it difficult for family members to provide support to people after childbirth. And one of the things that we know is that in particular for Black mothers, we recognize that there were not only those concerns that everyone had about the fear of acquiring COVID during that time period, but also the impact of not having visitors and not having social support also made a situation that already existed worse. And so thinking about this issue of overall pre-existing condition or pre-COVID distribution of depressive symptoms by race ethnicity, we know that Alaskan Natives and American Indians are Native peoples also have the highest rates of postpartum depressive symptoms. But that non-Hispanic Blacks also have have higher rates as well. And these data are probably not so surprising to you all, but I want to suggest that this prevalence of the difference in terms of postpartum depressive symptoms were certainly made worse by the pandemic and the consequences of the economic insecurity, lack of social support, lack of services being able to be offered, including home visiting services, which we know are fundamental to be able to provide assistance to the people who qualify and who need it. And so we are sort of in this, space where we are recognizing that we need to really kind of get down to the basics here. We really need to sort of say and recognize that what this pandemic did is reveal the inequities and that were in many cases influenced by race right here, right now. And so this is the time where we need to sort of recognize that even before this, right, we know that Black women were less likely to receive treatment and less likely to see follow-up treatment for depressive symptoms, that part of the reason that the Black women don't seek follow-up treatment are rooted in experiences of structural racism, the legacies of slavery. And these are, even though it can feel like that was so far in the past, I want to suggest that that's the unfortunate reality, is that we are currently living with that history. We are living with that history, whether we acknowledge it or not. And it appears again and again. And so the level of distrust that Black women may have for the medical system doesn't just come from a sense of, vague idea. It comes through generations as information is passed down. It comes from the reality of the experiences during pregnancy and birth. It comes from the experiences of being a Black woman and this recognition that what we are looking at is not what it appears, and that in fact, we need to be able to look even more deeply, certainly resonates now, today, more than ever. I also want to just, again, sort of in my, objective here to kind of connect the dots, also connect what we are seeing with the issue around postpartum mental health concerns for Black women to the maternal mortality issues that are happening across the United States. And by maternal mortality issues, I mean the disproportionate number of deaths that happen for Black women as compared to white women. We're talking a 2 to 3 time greater rate of deaths. Data and studies in New York City identifies a 12-time greater risk of women dying either during pregnancy or in the 42 days after childbirth. And this is something that, again, is not only a problem here in New York State, in New York City, but is a nationwide concern. And this issue around Black maternal mortality, and I would argue Black infant mortality, are also connected to the issues around how people are treated, the stressors around racism, and the impact that that has on women's bodies. Because when we look at the leading causes of maternal mortality in the United States, certainly we can see that there are conditions that can be addressed at the hospital setting. So hemorrhage, for example, certainly in some cases, many cases happens within the hospital setting, but can also happen after discharge, in particular if women are discharged quickly after birth, as we saw during this COVID pandemic. We also recognize that in addition to the clinical conditions like infections, cardiomyopathy, and embolism, and preeclampsia, mental health conditions also play a role in maternal mortality as well. And so I want to suggest that this is not something that is disconnected from the issues that we've already been talking about as it relates to the reasons why we see these greater death rates among Black women as compared to white women, but we also see those higher rates of mental health concerns and other conditions as well. And again, when it comes to looking at the issue of maternal mortality and overall health disparities, we know that the risk factors that pre-existed, right, the risk factors that people present with on an individual basis are necessary but not sufficient to be able to explain these higher maternal and infant mortality rates. And so recognizing that, sure, getting prenatal care early would obviously be a benefit. That, sure, being able to have be at a healthy weight before pregnancy is helpful. That, sure, being able to address chronic health conditions before pregnancy would help with outcomes. But I want to suggest that what we are actually looking at when we use the example of maternal mortality is that the difference that we see is not fully explained by those individual behaviors or lifestyles. And so an African-American woman who initiates prenatal care, for example, in the first trimester still has higher rates of infant mortality than non-Hispanic white women with late or no prenatal care. Black women who are at normal weight still have a higher risk of dying during the perinatal period than non-Black women who are obese. We also know that socioeconomic status is not protective for Black women, that Black women who are college educated still have a 4 times greater chance of dying of issues related around pregnancy and childbirth and the postpartum period than a less than high school educated white woman. And so putting all of those pieces together makes us realize, like, either to make us feel, overwhelmed, like, oh my gosh, look at all of these problems, right, with all of these different conditions, or could we argue that they actually are the same problem in terms of the root cause? And so I want to suggest a perspective that I'm sure many of you are familiar with, the life course perspective, that helps us to, make sense of all of these different conditions and concerns and why are these happening. So the life course perspective says that social and economic forces affect African-American women's development across the lifespan, and specifically those social and economic forces have a physical effect through stress. The recognition that exposure to those social and economic forces are what cause stress responses within our bodies. And so we know that not only does that stress response sort of happen, under acute situations, but the life course perspective posits that those chronic exposures to stress leads to the production of stress hormones within our bodies, which leads to higher allostatic loads within our bodies over time and increases the burden on our body systems. And during pregnancy, this presents as immune suppression. So those higher stress hormone levels presents as immune suppression, which increase risks to infections, which it turns out is the leading cause of prematurity and low birth weight, which is the leading cause of infant mortality. And so recognizing the sort of connection between these sort of external factors of how people are treated, our social conditions, the economic forces that we are in, and how that is then taken inside the body through the production of stress hormones, how that production of stress hormones over the life course can have detrimental effects without doing anything about it, right? Doing anything specifically in terms of lifestyle or behaviors. That's already baked into the outcome. And so as we also can recognize, this life course perspective can have, very, very detrimental effects by racial ethnic groups. And so the idea that Black women are coming into pregnancy, for example, with higher loads of stress than white women is something that we recognize is not fair. And the last bullet on this slide really, I think, highlights this sort of something that, again, might not be obvious to the eye, might not be something that we can do a test for, but yet exists. That even though Black women and white women might express the similar level of stress, yes, I'm feeling, stress on a level of 1 to 10, I'm feeling a 5, and both can say that they're feeling 5, that level of stress. The truth is that the Black woman, because of her exposure to a lifetime of that increased allostatic load, actually has a higher rate of risk than that white woman, even though you're not even feeling it. And so I want to suggest that this perspective really highlights the really devious nature, I would say, of the way that racism works within the bodies of women in this example, Black women in this example. And so when we sort of start to, piece that apart, it really kind of gives us a recognition that even though it's happening to me, I can't even identify it, because this is something that has been happening not only, the literature says, not only since the day I was born, but actually when my mother was born. And so we also know that the concept behind the life course perspective is that sadly these higher tendencies to be able to absorb those stressors can be passed down through generations. And so when I think about this issue and what we're looking at the tip of the iceberg with maternal mortality, infant mortality, perinatal mood disorders, we can look at those data and say, like, wow, that's a really big difference. But I want to suggest that we need to get at the causes of the causes. What's underlying that? Well, certainly, for maternal mortality, maternal morbidity or nearnesses are part of that. For infant mortality, we can look at preterm birth and low birth weight, as I mentioned, are the leading causes of infant mortality. But what are the reasons for that? And so that's where we start to, understand, well, maybe it's because of pre-existing conditions that were there in that population, lack of getting, healthcare or healthcare access, insurance access. Sure, we could say, but we would say, what's underneath that? And that's when we start to get at the concepts of toxic stress, vigilance, the weathering effect, the higher allostatic load that exists before I was even born, in addition to the way medical systems are structured. And underneath that is the structural interpersonal racism, the unconscious bias that presents between caregivers and patients, and the lack of economic stability. And so once we start to understand that what we're seeing is not what it appears, that there are multiple levels underneath that, that allows us to have better tools to be able to deal with these issues. And so I want to suggest, when we are understanding the sort of what we're seeing and what are the causes, and indeed what are the causes behind the causes, that we need to present a different framework to be able to address this. And this is not to say that individual support and therapy and access to care is not necessary. It absolutely is. But as we move towards a policy perspective, we also need to change our framework to make sure that it's aligned with the real problem that we're addressing. And so I was interested to see that SAMHSA has sort of identified behavioral health equity as a perspective to be able to address some of these issues. And so not only does it identify the right to access quality healthcare, but also the right to access prevention, treatment, and services, but also that they are sort of putting it out there that they need to be able to also address the social determinants that impact what we see with our eyes in terms of the way people are presenting with mental health concerns. And those social determinants are things like employment, housing stability, how culturally responsive or culturally appropriate that care is. And so this concept of behavioral health equity makes us recognize that we absolutely need to treat what it is that we see, but we also, if we are really going to get at the root to be able to address this issue, we need to be able to understand why this exists in the first place and to be able to address those concerns. Because one of the things I think that we can all recognize is that as we are all living through this pandemic and the consequences that continue to reverberate and reverberate on much higher frequencies for those who were already in precarious situations, that we have to recognize that the strength of community ties needs to be reimagined. That recognizing that the policies that are implemented might not have an equal distribution on all people. And so the recognition that when we start to address issues around behavioral health equity, we have to also, again, not only say like, oh yeah, we kind of need to, take the disparities into consideration. No, we also have to recognize what are the strengths within these different communities as well. And I'm highlighting this because I think that this is often underlooked and underappreciated when it comes to understanding the concepts around how do we address health equity. And one of the things that I think is extremely important is to recognize that there are assets and strengths within all communities. And so for us to just look at, the places where the worst outcomes are and see that as a deficit, we have to also be aware of what are the protective factors? What are the ways that any people are able to function under pandemic times, under any kind of stressful times? And so the recognition that there are assets and strengths within communities, and I would argue that for Black women, we are talking about 400 years of oppression that, there are strengths to be able to make it to this far. And so one needs to be aware of that and to draw upon that, because that is where our action is going to happen. The fact that we have seen that that when we double down on those strengths and those assets, that it grows. And so this idea that many are also addressing when it comes to dealing with Black maternal mortality and other issues is this concept of listening to Black women. And listening to Black women is part of identifying and honoring those assets. And so the listening to Black women piece sort of says that maybe the solutions of how to do this are actually not out there in, research, which of course is important, but maybe the answers are in the people who have survived 400 years of racial oppression. And maybe we can listen to see what it is that they would have to offer. So I want to share with you all this 2-minute video, maybe it's 2 minutes and 15 seconds, something like this, that is an example of this idea of listening to Black women's stories, of being able to identify strengths in community ties, and to be able to appreciate and understand assets. So let's cross fingers that everything works out for me.
I was terrified of the idea of giving birth. Women screaming at the top of their lungs in agony are the images that come to mind. When I asked family and friends to share their birthing experiences with me, they all either said they had C-sections or were given all different sorts of medications to help them deal with the unbearable pain. I just felt in my heart there was another way. I started to seek out more information. I watched the documentary, The Business of Being Born, and was immediately horrified. I could not believe doctors scheduled C-sections around their vacations.
Okay, don't panic.
And told women things like, your baby is way too big to have vaginally. I get that sometimes you may need medical interventions, like C-sections. I mean, I was born prematurely, and a C-section was the only way for me and my twin sister to be born. But my great-grandmother had all of her 12 children at home, without a doctor and without an epidural. So how could doctors say our bodies were not made to give birth naturally? The documentary explored the options of having a midwife instead of a doctor. I immediately Googled midwives in Long Island and set up an appointment. My midwife, Dale Cook, was so laid back, patient, and explained everything thoroughly. Not one time did I feel rushed. It was such a relief because I remember always feeling rushed with more questions when I met with doctors. After seeing my midwife, I was on a mission. I made sure I ate a balanced diet consisting of a lot of vegetables, and I started taking a prenatal yoga class. I felt so relaxed I could just fall asleep in the studio every night after class. On September 14, 2014, my water broke, and 44 hours later, I was able to deliver my beautiful baby boy naturally, without the use of medication. I felt so empowered, and I cried like a baby once I looked into his eyes. I could not believe I did it, and I was the one in control.
Okay, so let me see if I can go to the next slide here. So I want to suggest that Sherelle's story is one of thousands of stories, millions of stories that exist. And the idea that we can look at the assets again, and you know, Sherelle used words like empowered. She was proud of herself for based on what it was that she did. So let's imagine what that does for a mom, right? To be able to have that sense of self-efficacy, and the ways that she can be able to address that, and how that then might play out in different aspects of her life, even after she goes home. And so when it comes to thinking about this issue of assets, I want to suggest that we are really looking at a more equitable perspective of how to be able to address the issue of maternal depression and the inequities that are behind it. And so thinking about this concept of focusing on the assets within the communities, listening to Black women's stories, is also about broadening that focus on overall wellness and not just the outcome of a healthy baby. And I want to just also, you know, end by us sort of this concept of reframing, as I hope that I've been trying to do throughout this presentation, and trying to be able to connect the dots between the outcomes that we see and what lies underneath, is that we could argue that maternal depression is a reproductive justice issue. And for those of you who aren't familiar with reproductive justice movement, it was a movement that was started by Black women to identify the sort of overall rights that people, all people should have around issues of birth, pregnancy, contraception, and being able to raise your child. And so the concepts then are the same, that we need to be able to have access, not just choice, right, but to have true access that's also culturally congruent and appropriate. Also to recognize that we have to acknowledge and address that matrix of race, class, and gender and power and that those oppressions can lead to negative birth outcomes, but also to mental health issues as well. And our work then becomes not only educating the community about these issues, but also challenging the way that medical systems are approaching these issues, especially around unconscious bias and treatment of Black birthing people. The reproductive justice movement says you need to center the most vulnerable and advocate across all issues that affect the sort of, again, root causes of those differences. And so thinking about that perspective really brings us to the point of considering the causes of the causes, for us to really sort of forthrightly acknowledge that structural racism is at the core of these differences, that our approach needs to embrace social justice and equity. And in the same way that this coronavirus pandemic had quickly made us realize that these are inequities that it revealed inequities that had already existed, that it actually shares a root cause with the mental health disparities that we care about and want to be able to address. And so that's my end. I thank you all for your attention to this, and I'm happy to be able to answer questions as you see fit. And so thank you again for your time and attention. Oh, do you want me to change to be the host?
Great. Okay, so I take over the host.
Thank you.
I'm going to invite Sonia to come back on and just kind of lead us through the end here.
Yes, I'm back. Thank you very much, Dr. Hackett. That was really a very important presentation, and we greatly appreciate you really connecting the dots of health equity data and maternal mental health. And also a special thank you for including Sherelle's story and her voice here also. I think that the information that you've shared today with us will further help us to increase our knowledge here so we can all work together to further create meaningful solutions for New York State families. So thank you very much again. And before we move on to Q&A session with Dr. Hackett, we want to ask one last question regarding the material of this webinar series. We want to make use of this webinar series as a way to bring together professionals in the community, those in the community in the field of perinatal mood and anxiety disorders, so we grow this network. So if there are some topics that you would like to see in this webinar series in the future, please feel free to add them right now into the chat, or before we log off at the end of this discussion. So right now we have about 10 minutes left. So please feel free to ask any questions now to Dr. Hackett.
Hi, Dr. Hackett, it's Brittany. It's not so much a question so much as it is just the appreciation of the iceberg slide that you had. I really appreciated the layout and how you went through that, so thank you. I think you really reframed some of these topics in a way that made it easier for me to understand as well.
Thanks, Brittany, I appreciate that.
Hi, Martine, it's Mary Banahan. Great to see you. Wonderful presentation, fantastic. I loved Sherelle's story. I was crying watching it because I loved how she went from a mom who was fearful to a mom who was empowered and felt strong, which is what we want for moms. I love how she took charge of her own health and she did her research. That was phenomenal. I really, fantastic. And the whole thing was really very, very beneficial, shedding light on, you know, we all know the disparities, but sometimes seeing actual numbers. And I was just involved in an IPE session with the med school talking about root causes that you were discussing and doing the 5 whys, going back, well, you have a problem. Well, why? And really, I think that would apply so well to this real in terms of Black maternal health in general and Black maternal mental health, going back to really the root of what's going on. So really great presentation. I enjoyed it very much.
Thanks so much, Mary. I mean, I think that that really does, it's one of those things that, like, when you realize, you're like, oh, wait a minute, that's what it's about, you know? And I think by doing that, and I like that idea of like the why and, sort of unpacking the, getting to that root cause, but it's also frustrating, right? Because it's like, oh, wait a minute, now what do I do? I can't like just write a prescription for that, And so I want to suggest that what does that mean? It means that, advocacy. It means, the ability to, form coalitions. It means the ability to try to, like I said, draw on the strengths that already exist within people, the assets that already exist, because a deficit model is not going to get us anywhere, So we need to build on what is already there. And that sense of building, I would argue, especially during a pandemic, might even be even more possible. So if we can try to find any kind of, lightness here during this pandemic, is that things are so broken that perhaps it's possible to rebuild.
So we have 5 minutes left. So just a reminder, please, any future topics that anybody is interested in, please add to the chat, and please continue to ask your questions of Dr. Hackett.
I left them speechless, Sonia.
You were so thorough in your presentation, but I also think you really have started people thinking how they can further get involved and maybe begin to further change practice. I would also like to say, as we're beginning to wrap up here, that we would invite everybody to continue on with us in this Moving on Maternal Depression webinar series. Our next topic is going to be Black moms, breastfeeding support, and maternal mental health. So we hope people will join us for the next part in this series. Are there any other questions of Dr. Hackett? Any other or overall comments? Dr. Hackett, is there anything that you would like to share as we wrap up?
Yeah, I mean, the one thing I just want to sort of emphasize is the idea of, centering those who are most vulnerable and having them be, really have that sense of active, respectful, and authentic community engagement really is going to be necessary for us to be able to address these issues. And I think that sometimes that's sort of put out on the margins and thought about, I'll do that later. But I would suggest that it is absolutely necessary throughout the process of policy change, of education, to really center the people who are the most impacted.
Well, thank you. Thank you so much. And thank you for everyone for being with us here today. And as we said again, we're inviting you to continue on with us. And Dr. Hackett, we greatly appreciate your time and your contribution to this series. So thank you very much.
Sure, no problem.
Okay.
Bye-bye.
Thank you. Bye, everyone.